We will be using this test and tests like this a lot more in the next 5 or 10 years. This is early on. It's a test that you can use now. You can order it. It's a blood test. And I'm going to present some of the data, and Alexander will present others about using this test. And we'll be very interested in taking your questions about it and over these next period of years exploring really how best to integrate this into our diagnostic algorithm. My disclosures, I'm a consultant for CardioDx, and as I said, I've been working with them for about 4 years and was the PI for a study called COMPASS that we're going to talk about now. I also do a good deal of nuclear work, and so listen with interest to Dr. Ladabo's comments, and so we'll address those a little bit. I told him I was going to tweak them a little bit to have some fun. I work with Astellas. I helped develop a adenosine walking protocol. I helped develop the regadenosine product and regadenosine walking. So nuclear is near and dear to me. And I also work with Forest Labs, which with a research grant, which has another pharmacologic agent. And my biggest disclosure probably is I'm the past president of the American Society of Nuclear Cardiology. So I was cringing as at getting those comments. Nuclear's been very good to me. And so I look at the similar articles that he in a little different light, but it'll be up to you. You're critical thinkers. You're members of the ACP to see what you think and what future articles show how best to look at these things. Looking at the same paper, this was indeed astonishing, and we didn't know that we were both presenting this slide. I will point out that in this lab, what they did at Cedars is they took patients who came in for diagnostic testing who didn't have a previous MI or revascularization. And so it turns out, 24% of their patients who come to Cedars have had known coronary disease, for example, and so they were excluded. So if we take those patients with known coronary disease and say, well, half of them will be positive, that gives probably a little more accurate. So about maybe 15% of nuclear tests being positive at Cedars now. Much different. When I was at Cedars 27 years ago, 50% of our tests were positive. And then when the slide starts here, 40% were positive. So I started back here just with thallium and with exercise MUGA, for anyone who remembers that. I think we have a past president of the ACP. You'll probably remember exercise MUGA. That was tough to do. So people were very often positive, and now they're very often not positive. And nuclear testing, if you remember, is best for people with intermediate likelihood. People have a good chance of being positive. That's where the test works. But now we're using it a great deal in people who have a pretty low test of being positive. So our accuracy is not going to be as good as we expect it to be and not going to be as good as we see in the literature. So the challenge with testing a low-risk population is that you take a test that's, say, 85% accurate, like a nuclear test, for example, and then you apply it to a low-risk population. The chance of a positive test being a false positive gets pretty darn high, maybe 50%. And so in the data that Douglas has showed, that Dr. Ladapo showed with many tests, people having a positive nuclear test and then a negative cath, that's often because nuclear testing now is done in low-risk populations. And looking at the increase in nuclear testing, what was previously shown was really was this decade here in the 90s, the increase. More recently, nuclear testing has plateaued. And so now, since 2007, nuclear testing has gone down every single year. When the appropriateness guidelines came out from the American College of Cardiology and the AHA, recommending particularly against an annual nuclear test, partly because of the radiation burden, nuclear testing has continued to go down. But more recent data from Cedars and from Mid-America Heart continues to show, despite less testing, that patients are very often negative. And let me put another data point or another group of data points in to think about with this. This shows a decrease in cardiac death rate. This is absolutely remarkable. If we look at the chance of age-adjusted death, here's total death, here's cardiac death in America, here's cancer death, and then other causes of death here. This is stroke. We see a decrease in the age-adjusted death rate from about 1450 down to a few years ago, down to 800. And most of that is this decrease right here in cardiac death. Cardiac death, the rate of cardiac death since 1960 has been going down 3% a year. Every single year it goes down 2%, 3%, 4%, sometimes 5%, including the last decade. Now, as a nuclear guy, I'd like to think that finding disease with nuclear testing and cath and fixing it with angioplasty has helped part of that. Perhaps, we'll see. And also prevention has helped. But we have had a phenomenal decrease in our death rate from cardiac disease. And so if you'll see here, cancer has been going down a little bit. It's going down about 1% a year. So within the next year or two, you'll read in the paper that cancer is the number one killer in the United States. And look at the difference here. It used to be almost 3 times as amount. And that's basically when NIH and the American Heart Association started pouring money in research with what was felt to be an epidemic of heart disease here. It's had just a huge influence. And you can see it's not gone down when bypass surgery came out, when angioplasty came out, when statins came out. It's come down every single year. So it's the incremental things that you're doing, taking care of your patients, as the woman said there, listening to patients, taking a history, doing a physical exam, doing the right thing, putting them on statins, using guideline-based medication. We have changed America. I mean, it is astonishing. So in the same period of time, we've had about a 10-year increase in longevity. It's remarkable, and it's one of the reasons that we're in deep trouble, maybe not deep now, but we're in trouble financially, taking care of, with Social Security and taking care of our older people. Similarly, in Europe, we've had this dramatic increase in longevity. A lot of that has been the change in cardiac mortality. So let's get into this test. Actually, so the question is that I had when I started working with the scientists at CardioDx, is there a blood test for atherosclerosis? And if you have atherosclerosis, what's the likelihood you have coronary disease or an event-causing event-causing type of atherosclerosis? And so they developed a blood test where patient's blood is drawn, sent here. 2 days later, you get the results back. How did this, a blood test, a simple blood test, I say simple, it's simple for the patient, but it's quite complex in terms of measuring the RNA. How does that compare to a full-blown 3-hour nuclear test? Inflammation is a big part of atherosclerosis. It's an inflammatory process. When we get LDL into the underneath endothelium, it's like an infection. It's an inflammatory process. And I think a lot about inflammation. I happen to be the lead physician for the research group that presented at the ACC and released about 5 weeks ago the study of mummies. I don't know if some of you probably heard about it. We published it in Lancet, where we found atherosclerosis in ancient mummies. We imaged 137 mummies from around the world, found that 4 different cultures had atherosclerosis. And let me show you an example of that. This is a woman with coronary disease and aortic arch calcification who's 50 years old, who lived in the Aleutian Islands about 150 years ago, and she had coronary disease. So what we've got here, this is her right coronary artery, and white is calcium. And we found in mummies that it turns out much of their body disintegrates, but calcium, as you might expect, stays. So this is her right coronary artery here. This is her aortic arch. This is her calcification of the left anterior descending and part of her aortic valve. And we were amazed. Atherosclerosis in ancient Egyptians, ancient Peruvians, and American Indians, Native Americans who lived about 2,000 years ago along the Colorado River. And so one of our chief hypotheses is the infection burden that they would have had. So these populations all lived before antibiotics, and they lived before germ theory. Okay? And so they would have had a very different environment, very unhygienic environment than we did. So hunter-gatherers currently, there are a few still tribes and such in South America, for example, have infections about a quarter of the time, either dysentery or respiratory infections. So would have a CRP of 10 or 20, for example. So one of our beliefs with these mummies, one of the reasons they had atherosclerosis is this this inflammatory burden that they had. So let's look at the study design of this study. This was published about 2 months ago in Circulation Genetics. And what we did is we looked at over 500 patients. Diabetics behave differently in terms of a blood test, and that's still being worked out for diabetic patients. So we took non-diabetic patients. who had an indication for a nuclear test. Typical chest pain, atypical chest pain, so are being referred by a cardiologist, in this case, for nuclear stress testing. It was a very well-designed trial, prospective, multi-center trial, 537 patients enrolled in 19 U.S. sites with a very clear-cut statistical analysis plan identified at the beginning. So not like looking at the data and seeing how it looked, but saying this is how we're going to analyze the data. The mean age was 56 for our patients, which is a little lower than the typical nuclear population, so a little lower risk patient. These are not hospitalized patients, so they're less sick. They're outpatients. But so these are the patients that would be seeing you with atypical chest pain in 58%, non-angina or typical chest pain, typical angina in 20% each, for example. And so we defined obstructive coronary disease as a lesion of 50% or more. And that's typically what we do, 50% or more. And we looked at that quantitatively so that in a core lab that Alexandra did and Matt Budoff did on the CT side. And in a core lab, what's typically called 60 or 70% by the site, by the cardiologist looking at it, quantitatively looks more about 50%. So these are lesions so we called a patient having disease if they had a 50% quantitative lesion, which correlates with about a 70% lesion by eyeball, for example. And so our primary endpoint of the study was how did this score compare by ROC analysis. And so let's look at the data. So let's focus on the bottom part of the slide here, this group here. So again, we have patients who had typical or atypical chest pain, 537 patients enrolled. See it on both sides? We can. Okay. So of those patients, 431 had all tests. Some of the patients had a negative nuclear test and did not want to get a CT scan, which was part of the protocol. Some didn't get the blood test, some didn't get a cath, or some didn't get all three of the tests we want them to get. So of these 431 patients who were referred for nuclear testing, they got a nuclear test and then they got a score. Physicians weren't told the results of the score, so they just treated them based on the nuclear test. Of those 431, 48 had a positive nuclear test, 28 went to cath. Of those 28 who went on to cath, 12 had obstructive coronary disease, so significant coronary disease, so about 40%. Those patients who didn't go to cath, even though they had an abnormal nuclear test, they were being treated medically, they had a CT scan to look for coronary disease. And of those who had the CT scan, a coronary angiogram, CT coronary angiogram, 3 of those went on to cath and 2 of those had coronary disease. Of those 20 who had a CTA, or cardiac CT, 3 had coronary disease of 50% or more. So to summarize this group, there's 48 patients that had a positive test. About half went to cath. About half of those had disease. About half had a cardiac CT as part of the protocol to see how accurate nuclear was and how accurate this test was. And of those, a small number had obstructive disease. Now, if we look at those patients who had a normal nuclear test, typically in a study, nothing would be done with them. We'd be treated medically. But in this study, what we did is we wanted to see, did this score, how did this compare to nuclear testing? Did the patients have disease, either important disease or mild disease, for example? So those patients went on to cardiac CT. So 383 people had a negative perfusion score. Of those, almost all had a cardiac CT. 5 had a cath, even though they had a negative nuclear test. Of those who had a cath, 1 had coronary disease. Of those who had a CTA, 378, a small number went to cath, 26. 14 had cath confirmed there was important disease. And important disease was found in about 9% of these who went on to cardiac CTA. So the majority of patients who had obstructive disease were actually in the normal nuclear group compared to the abnormal nuclear group. Okay? Now, nuclear testing looks at something different than cath and CTA. So nuclear testing looks at ischemia. Do you have lack of blood flow versus do you have anatomy? Do you have disease? Because you can have a cath with 70% stenosis, as you know, and not have ischemia. So we're a little bit comparing apples and oranges here, but mostly nuclear testing is done to see if you have important disease. So we found some of these patients who were not apparently ischemic had disease, but they wouldn't necessarily be treated. For example, and wouldn't it be nice to know if these people had significant disease, even if you weren't going to do a revascularization on them, to treat them differently than you might just if you knew they had a normal nuclear test, for example. And again, we're using nuclear testing, as Dr. Labadeau suggested, in a low-risk population, and it's not performing all that well. The majority of people who had disease were in the normal nuclear test population. Okay. So again, we're using nuclear not to its best advantage. So as I said, the primary endpoint was how did it do with the receiver operating curve, and shown in green is how the score did compared to clinical judgment as manifested by the Diamond and Forrester test, which talks about how the age of a person, the gender, the type of chest pain they have, or another clinical judgment test, a Morisi score, which includes diabetes and hypertension, diabetes and family history. So if we just looked at clinical information, this gave a certain amount of information, and the tested score gave much more information, had an ROC curve of 0.79, which is a very high ROC curve. 1 would be a perfect test where it goes straight up and straight down. Random would be 0.5, would be this blue line here. So also very interesting is that it's a continuous test, a continuous variable. And the more disease we have, the higher this test score is. So we used a threshold of 15 as an abnormal test. And we'll look at that in more detail. A score of 15, the highest we score is a score of 38, and you can have a score of 0. So what we found here, this shows the score, those who had 0, those who had 10, 20, 30, and up to 38. And in green, it shows those who had a 25% stenosis, and these are the 95% confidence limits. And those who had a 50% stenosis with the 95% confidence limits in blue. So those who had a score of 10, which is 141 patients, score of 20 was 266. But let's take those who had a score of 10. The chance of them having a 50% stenosis or more is almost 0. It is way down here. The chance of them having a 20 stenosis between 25 and 50 is about 20%. If someone has a score of 25, then their chance of having obstructive disease is about 30%. The chance of having mild disease is getting up to close to about 60%. So it's a test. For a diagnostic test, they're typically yes or no. Nuclear test is yes or no, and it can be more or less abnormal. There's a gradient there. So if we group it categorically as opposed to continuously, if we take those patients who had a score of 1 to 15, which is almost half of the patients, most of them, 75%, had no stenosis at all in their coronaries, and some had mild, some had a little bit more, and only a small number had disease over 50%. Whereas if the score got higher and higher, you can see more and more burden of disease. If we compare now nuclear to the score, nuclear didn't do as well as I would have hoped as an ASNC representative. We show here the same receiver operating curve, a 0.79, and nuclear testing based on the site read, shown here in light blue, and based on an expert lab who got the images, reprocessed them, and used expert read as opposed to the site lab, had an ROC of 0.63, shown here. So using as a gold standard CTA, cardiac CT, or cath, nuclear was significantly outperformed by this score in this population. Now, how could we, as we think about it, and I'm not giving up on nuclear yet, how could we potentially use these two tests together? So one potential is to use, for atypical chest pain, for example, or patients in this population, use this test that has a high sensitivity. That is here, there's an 89% sensitivity, whereas the negative predictive value is also very high, 96%. So it's finding disease. If you do it, it's above 15, there's a pretty good chance they have disease. But if they don't have a high score, they have a negative predictive value, only a 4% chance they have important disease. Okay? So if you compare this to nuclear is very specific. If a nuclear test is positive, there's a very good chance they have it, but it's going to miss. Sensitivity is much less, 36%, and its positive predictive value is lower. So when you think about evaluating someone for an important disease that you don't want to miss, it's best to use a high sensitivity test initially, and then use a more specific test second. So it's like for mammography is going to find a lot of false positives, and then you can do something thereafter. So this is like mammography early, and then only testing those who are positive to ferret out what's truly abnormal in terms of ischemia. So a neat new opportunity. So if we were to use this algorithm in this patient population, 431 patients who got it in score, and if we unblinded, for example, in retrospect, and if they had a score of less than 15, we did no further testing, that would be 199 out of 431 patients. Only one of those patients had obstructive disease. So we missed only one of those patients using this algorithm. If we took patients who had a positive score of 15, went on to nuclear testing, and they had a negative perfusion testing, we could do potentially no further testing because they may have had atherosclerosis but not ischemia. You're not going to go and fix that, although you might well treat it with a statin and potentially aspirin. Those who had a positive nuclear test, here, 34 out of this 232 patients, then those patients you might well send on to cath, and if you cath those patients with a positive nuclear test, then about half of them, 47%, have disease. So you're going from a low chance of being positive, as discussed earlier, to a yield with cath of about 50%. So this is a very reasonable algorithm to think about, decreasing a radiation burden by about 46%, with 46% fewer MPIs, 29% fewer caths. So as someone who's considers themselves a thought leader in the nuclear area, we need to figure out how to use this test because it's too important to ignore at this point in time. And as I finish up, if you look at 6-month follow-up for MACE, for death, MI, stroke, etc., if we look at the 97% of patients who are available for follow-up at 9 months, 25 got an intervention. All but one of those who got an intervention had a score above 15. 2 had late MACE, 1 MI, 1 stroke, 1 had late revascularization. All of those had a score above 15. So just using in this population, it performed remarkably well. So in conclusion, this test was a predictor of obstructive disease in the patients who often present to you as an internist. With using a threshold of 15, sensitivity was high, negative predictive value was very high, and it outperformed nuclear testing in this population.